Hello, welcome to another episode of Cincinnati Sessions. This is a production of the University of Cincinnati Internal Medicine Residency. I'm your host, Matt Kelleher, and today we're going to be talking about loop diuretic dosing. Okay, let's get started with a case. A 55-year-old male with diabetes and hypertension, heart failure with a reduced TF of 25%, gets admitted with dyspnea on exertion, orthopnea, a 2-liter oxygen requirement, and his weight on admission is 245 pounds with a dry weight of 210. There's his blood pressure, JVP's elevated with 2+ peripheral edema. There are his labs, all consistent with a heart failure exacerbation, and his medications, ACE inhibitor, beta blocker, aspirin, statin, and furosemide 40 milligrams daily. Okay, and here's your question. Which furosemide regimen would be best for diuresis? 40 milligrams IV BID or 80 milligrams IV daily? Or maybe you'd like to argue for a completely different dosing regimen. At this point, pause the video and try to answer this question yourself. Use whatever evidence you have at your fingertips and any knowledge that you may already have. If you're next to someone, present the case, try to discuss it together. And after you try to answer the question, resume the video. Okay, so if we're going to answer what's the right loop diuretic dose, we need to understand how loop diuretics work. And to understand how loop diuretics work, we need to understand some normal physiology in the kidney. And this is, again, normal physiology at my level. So this is a picture I've drawn of a nephron. We're going to focus here on the ascending loop of Henle. Now, what happens in the ascending loop of Henle is normal, under normal circumstances, sodium is pumped from the tubule into the interstitium. Now, water loves to follow sodium, but in the ascending loop of Henle, water cannot follow the sodium. The reason that this is beneficial or works is we are going to make a very salty interstitium, which is very important, as I'll show you in just one second. As you move to the distal convoluted tubule, sodium and water can both be reabsorbed here. And as you move to the collecting tubule, water becomes permeable now. And since we have a very salty interstitium, water is saved, and what is left becomes urine. So we're able to concentrate our urine and only pee out the water that's needed. Now, when we're giving them loop diuretics, look at what's changing. Now, in that ascending loop of Henle, we are blocking the ability for the tubule to pump sodium into the interstitium. So we have a much less salty interstitium. Now, as a result, you get to the distal convoluted tubule and you can still reabsorb sodium unless you have a thiazide on board. And then we move into the collecting tubule, where now, with a much less salty interstitium, we have a much less gradient for water to be reabsorbed. And what do we get? We get more water staying in the collecting tubule and more water being urinated, and basically water, losing water, which is the whole point of the diuretic. Okay, now that we understand how loop diuretics work, now I want you to understand the key principle that I want you to learn from this session. That is illustrated best with this light switch. Now, if you're like me, you think about most medications as higher doses make them more effective, right? Think metoprolol. I increase the dose, I get better heart rate control. When you think of loop diuretics, I want you to think about a light switch on and off. This is the key principle. Look at this graph. If you look at this graph, you can see on one axis it says diuretic. Think of this as the diuretic dose, and the other axis is natriuresis, or urine output. Now you can see you have to increase to a certain dose before you get any really significant urine output. And very quickly, based off the steepness of the curve, you get to a dose where you're at your maximum amount of urine output. This is called a ceiling and a threshold effect. And this is a picture from a tutorial by this doctor at this Twitter handle that you can check out. It inspired most of this video for me. So if loop diuretics have threshold and ceiling effects, then this is critical to understand how to dose them, right? If you are below the threshold, you're going to see very little urine output, and increasing the dose above that once you hit the threshold is not going to give you a lot of significant or a lot of increased significant urine output. Most of the things in the literature I have seen show that in the first 3 to 4 hours after giving a loop diuretic, you should see somewhere between 2 and 4 liters of urine. This is called the dose threshold and is critical to understanding how to dose loop diuretics. Now, there's a few other keys that you'll need to understand if you're going to pick the right dose. Bioavailability. This is what makes furosemide so complicated. They say it's on estimate about 50% bioavailable, but they say that can range from 10 to 90%. This makes picking a dose very complicated when the bioavailability is very erratic. versus torsemide and bumetanide, the other loop diuretics, which have much more predictable bioavailabilities. When it comes to half-life, bumetanide is a half-life about 1 hour, torsemide of about 3 to 4 hours, and furosemide right in the middle of about 2 hours. And then renal blood flow is the other key importance. As your GFR declines, kind of all of the loop diuretics are going to require higher doses because there's going to be less blood flow in the kidney, and therefore you'll need higher doses to achieve the same threshold. This is illustrated in this graph, but what's important is to see that the threshold and ceiling effects are preserved. So those still exist regardless of the poor GFR. Okay, so let's play with these principles of threshold and ceiling and make sure we understand them for the next time you dose furosemide. I've left the figure here of threshold and ceilings. Now, how should we dose the loop diuretic in this instance? Let's say 40 milligrams IV and the patient puts out 2 liters of urine. 80 milligrams IV and he puts out only 2.5 liters of urine. You see the ceiling effect there? So clearly the benefit in that case would be, let's give him 40 milligrams IV BID. Does that make sense? If we were to give him 40 milligrams IV and he only puts out 300 to 500 mLs, but 80 milligrams IV, he puts out 2 liters of urine, now we've found the threshold, right? 40 milligrams obviously had not reached his threshold, but 80 did. Therefore, there'd be no benefit to give him 40 milligrams IV BID. We would have to give him at least 80 milligrams IV and potentially even think about 80 milligrams IV BID if we're hoping to take more fluid off. So let's return to our case, the 55-year-old with heart failure who was being admitted 35 pounds up, who we wanted to diurese. The question that we asked ourselves was, what's better to pick for my diuresis, 40 milligrams IV BID or 80 milligrams IV daily? The answer, hopefully you've seen by now, is it all depends on the patient's threshold. And this is the key thing that I want you to learn. When you give a patient a loop diuretic, the best way to figure out if you've picked the right dose is to go back and see the patient 3, 4, 5 hours after they've received the dose. If they tell you, oh my goodness, I've been peeing like crazy, and their ins and outs show that they've put out 1 liter to 2 liters, you've probably reached their threshold. And in that case, there's not much benefit in increasing the dose. You can simply increase the frequency to BID or TID in order to get the maximum diuresis out of that patient. Okay, it's time to put these principles that you've learned to play. So let's use a couple cases and a couple questions to make sure you understand the concepts. You're in clinic and a patient's taking a dose of 40 milligrams of furosemide. It's causing great urine output for your patient, but there's still edematous. Would this be good or bad advice? Why don't you try taking 80 milligrams for the next couple of days and then call me with your weight? What do you think? How about this? You're in clinic, the patient's taking a dose of 40 milligrams. It's not working well for your patient and there's still edematous. Would this be good or bad advice? Why don't you take it twice daily for the next couple of days and then call me with your weight? What do you think? Here's a couple more questions for you to reflect upon. Why is torsemide, or why would torsemide might have some advantages over furosemide? A couple others that you might think about or even read more about if you're interested. Explain the physiology of how adding a thiazide, based off that figure I drew, might increase the diuresis of a loop. And explain why ACE inhibitors and NSAIDs actually might make loop dosing more complicated. Thank you for watching this Cincinnati session on loop diuretic dosing. Hopefully it was helpful, and be sure to check out other videos in the Cincinnati session. I want to draw your attention to my references if you'd like to learn more, and the top one being most important, which is the tutorial by this physician at this Twitter handle from March of this year, where he covers these exact same topics. If you'd like to learn more, I would highly recommend it. Have a great day.